Hello everyone, I am Vicente Roques and I work as an anesthetist at the University Hospital Virgen de la Risaca and Quirónsalud in Murcia, Spain. First of all, I would like to thank the organizing committee as well as the rest of members of Esra Europe for allowing me to share this lecture that was presented at Esra Europe Congress in 2022 in Thessaloniki. This time, I'm going to talk about regional anesthesia in spine surgery. The number of spine surgeries being performed has exponentially increased in the last 2 decades. This rapid growth is mainly attributed to the epidemic of chronic low back pain in developed countries. For this lecture, because the presentation will be in English, which is not my native language, I decided to have the help of an old friend. Hello, Alexa.
Hi, Vincent. Will be a great pleasure to help you throughout your lecture.
Thank you. It will be a great pleasure to have you helping me in this presentation.
I imagine that the audience will also be glad to get rid of your strong Spanish accent.
Complex spine surgery has ranked among the top 6 most painful procedures. Pain after spine surgery can be generated from different structures such as vertebral bone and capsules of the facet joints, ligaments, muscles, discs, and dural slips. Poor pain control has been shown to be associated with increased risk of wound healing, infection, length of stay, expenditure, and delayed mobilization. To know the innervation and therefore the generators of pain, it is essential to know the anatomy of the vertebra. Alexa, can you please explain the different parts of a vertebra?
All the vertebrae are formed by a vertebral body and a posterior arch. This posterior arch is formed by 2 pedicles, 2 transverse processes, 4 articular processes, 2 superiors and 2 inferiors, 2 laminae and 1 spinous process.
Alexa, something else we should know about anatomy of lumbar vertebra?
Each spinal nerve contains a mixture of motor and sensory fibers. They begin as nerve roots that emerge from a segment of the spinal cord at a specific level. Having exited the vertebral canal, the spinal nerve divides into 2 branches, a larger anterior or ventral ramus, and a smaller posterior or dorsal ramus. The spinal dorsal rami are the posterior branches of the spinal nerve. They innervate back from the occiput to the sacrum. The L1 to 4 dorsal rami tend to form 3 branches, medial, lateral, and intermediate, which are distributed, respectively, to multifidus, iliocostalis, and longissimus muscles. Anatomically, the common dorsal ramus and its medial and lateral branches surround the zygapophyseal joint, which serves as a pivot of the spinal functional unit. The posterior aspects of the discs and the posterior longitudinal ligament are innervated by the sinovertebral nerves. The posterolateral aspects of the discs receive branches from adjacent ventral primary rami and from the gray rami communicantors. Near their junctions, the ventral primary rami.
If the dorsal rami is responsible for the innervation of this posterior vertebral arch, our anesthetic procedure should be aimed at this particular anatomical structure. Am I right, Alexa?
You are absolutely right, Vincent.
Alexa, can you please explain to us something about ERA's protocols?
Enhanced Recovery After Surgery, ERAS, is a new surgery protocol that streamlines patient processes before, during and after surgeries. The program aims to shorten the length of stay for patients and facilitate early mobility and recovery while improving outcomes and patients' overall experiences. In all ERAS protocols, regional anesthesia plays a key role for adequate post-operative pain control.
Alexa, is there any ERAS protocol established for spine surgery?
Many institutes have protocolized their perioperative management of patients undergoing spine surgery. However, a widely accepted enhanced recovery after surgery, ERAS, pathway for spine surgery has yet to be developed. In 2021, Bertram de Bono together with other colleagues tried to create a consensus statement for perioperative care in lumbar-spinal fusion. With a moderate evidence level, the routine preoperative administration of acetaminophen, non-steroidal anti-inflammatory drugs, and gabapentinoids as part of a multimodal opioid-sparing analgesia strategy is recommended. With a high evidence level and strong recommendation grade. Use of intrathecal morphine, epidural analgesia, local regional blocks or wound infiltration with long-acting local anesthetics should be used to improve post-operative pain management. Only local regional blocks present weak grade of recommendation. Probably because we do not have any regional block that is adapted to the needs of this type of surgery. The routine use of multimodal analgesic regimens to improve pain control and reduce opioid consumption is recommended. Early mobilization and early physical therapy are recommended, with moderate and low evidence level. Hey Vincent. I don't know if you plan to do something by yourself or if you're going to spend the 20 minutes of your lecture asking me questions.
Oh, come on, Alexa. Stop complaining and help me just for a few more minutes. I promise the best place in the living room when we get back home. Alexa, what are the strategies we know we can use to improve postoperative analgesia and reduce opioid consumption?
In this paper, published in 2019 by Abdul Rahman Al-Boog and colleagues, review the evidence regarding the anesthetic management of blood loss, pain control, and position-related complications of adult patients undergoing complex spine procedures. For pain control, most interventions only produced mild analgesic effects, suggesting a multimodal approach is necessary to achieve optimal pain control after spine surgery. Regional techniques and non-steroids anti-inflammatory drugs were effective, but because of their risks, their usage should be discussed with the surgical team. Epidural analgesia reduced postoperative VAS score and postoperative day 1 and first 24 hours. However, the patients receiving epidural analgesia had 15 times higher risk for motor block. Additionally, epidural block may artifact electrophysiological monitoring. What would contraindicate the technique? Epidural steroids administered at closure during lumbar surgery showed reduction in VAS pain score at 24 hours, as was postoperative use of opioid analgesia. The study did not report analysis on the risks of delayed healing and infection. Intrathecal morphine from 0.1 mg up to 1 mg reduced in VAS pain score and morphine equivalent consumption compared with intravenous opioid at postoperative first 24 hours. The intrathecal morphine group, however, experienced more pruritus and respiratory depression. Intramuscular injection of local anesthetic reduced VAS pain score at 1 hour, prolonged time to first analgesic demand with no effect on pain score at 24 hours. Subcutaneous infiltration of liposomal bupivacaine did neither reduce pain score nor opioid.
Alexa, something else we should know about regional anesthesia in spine surgery?
In recent years, there has been a growing interest in the application of regional techniques for spine surgery. The thoracolumbar fascia plane block has been the one that raised the most expectations initially, described by William Hand in 2015. It's performed by injecting the local anesthetic between the multifidus and longissimus muscles, or between the last one and the iliocostalis.
There are probably a few articles that refer to this procedure. Could you please show us the most representative?
Efficacy of thoracolumbar interfascial plane block for post-operative analgesia in lumbar spine surgery has been studied. In this meta-analysis presented by Zhengxinhu and colleagues, randomized controlled trials, RCTs, up to December 2020 were collected. A total of 9 RCTs with 618 patients meet the inclusion criteria. The results demonstrated that VAR's scores for pain during movement and while at rest were markedly lower in the study G than those in the control group in all the post-operative periods. Meanwhile, PCA compression frequency, PCA consumption, and nausea rates were significantly lower in the TLIP group after lumbar spine surgery. In 2016, Mauricio Foro described the S block. Although this procedure was described for chronic treatment in chest pathology, currently there are numerous papers that have described and studied its results in spine surgery. Conciting injection of local anesthetic over the transverse process and below the erector spina muscle. One of the characteristics of this block is that IT seems to constantly block several dorsal nerves through a single puncture. The main controversy would be the diffusion of part of this volume towards the paravertebral space, and therefore the ventral ramus.
Same as in thoracolumbar fascia plane block, could you please show us the most relevant bibliography about the use of ESP block for spine surgery?
In this meta-analysis written in 2020 by John Ma and colleagues, the authors found 12 studies comparing S-block performed as analgesia technique versus no block for spine surgery. They concluded that ESP block reduces post-operative pain scores at rest and at movement at different time intervals except at movement at 48 hours, and significantly decreased opioid consumption in first 24 hours.
Any article comparing both procedures?
2 papers compare S-block, thoracolumbar fascia plane block, and no block. In the first one they conclude that both blocks may provide adequate pain control after discectomy surgery, with a non-superiority result. In the second, ESP block had better analgesic effects, and less pain scores in static states. Additionally, less frequency of PCA compression and opioid analgesic consumption.
Now is my turn, Alexa, take a break.
Would be great for the audience to hear your voice.
Oh, Alexa, you're killing me. With poor evidence, it seems that the ideal anesthetic technique is the one to obtain a bilateral and multi-level block of the dorsal rami of the vertebrae involved in the surgery. It seems mandatory that this procedure does not block the ventral rami of spinal nerves to obtain motor block or artifact on electrophysiological monitoring. Nowadays, thoracolumbar fascia plane block and ESP block seems to be the 2 most promising regional approaches for analgesia in spine surgery. The knee, hip, and shoulder surgeries have them all their own regional techniques defined as gold standard. We still do not have the one for spine surgery. We are on time of evolution and new proposals. I'm going to show you my proposal. Returning to the article already mentioned in previous slides, the anesthetic management of spine surgery is often challenged with significant blood loss, difficult pain control, and risk of position-related complications. Prophylactic tranexamic acid and optimal prone position to avoid abdominal cava compression are effective blood conservation strategies in spine surgery. Routine, preemptive, and multimodal combined use of gabapentinoids, ketamine, and opioids to optimize pain control after spine surgery are recommended. Recently, the use of thoracolumbar fascia plane block or ESP blocks have been described as a real option of regional techniques for pain control in spine surgery. In 1987, tumescent local anesthesia technique was first described by Klein for liposuction. This approach uses high volumes of diluted lidocaine and epinephrine to establish a beer block with hemostatic control. In 2010, Lalonde extended the use of tumescent local anesthesia to the hand surgery. It was known as wide-awake local anesthesia with no tourniquet, Wallant. Both techniques obtain an anesthetized and bloodless feel through superficial injection of epinephrine and diluted anesthetic. After using Wallant for different orthopedic procedures, we consider the possibility of performing injections on deeper planes reaching the larger caliber vessels as well as peripheral nerves involved in surgical area. We call it PVI, perarticular vasoconstrictor infiltration. Performing a subcutaneous, intramuscular, and perivascular tumescent infiltration, a simultaneous vasoconstrictor and analgesic technique is obtained for major surgery. We have described the technique not only for spine, but also in shoulder, hip, and knee, and we hope it will be published soon. Like many anesthesiologists, I started performing the ESP block as an analgesic technique in spine surgery with good results, but in some cases they were inconstant. However, retrolaminar injection, which was very popular in Asia, not that much in Europe and America, called my attention. Since the injection is performed in the depth of the multifidus muscle, it could be a good idea to perform the infiltration in its proximity to get ischemia and good analgesic results. We prepare a dilution of 200 ml of 0.2% ropivacaine. 1 mg of epinephrine is added to the dilution. So we obtain 200 ml of ropivacaine 0.2% with epinephrine 1/200,000. A two-step injection is performed. First one, a retrolaminar infiltration with tumescent injection inside multifidus muscle and thoracolumbar fascia. The second one along the surgery line over spinous processes. A total volume of 120-150 ml are injected depending on surgery and patient. With patient in prone position, we will try to identify the shadow generated by laminae looking for the horse head sign. The injection will be performed in plane from cranial to caudal at the retrolaminar space inside the multifidus and erectorospinae muscle and thoracolumbar fascia. You can see inside multifidus muscle all the local anesthetic injected. On a second step, we will inject on skin and fat tissue over spinous processes along the surgical line. This injection can be performed blindly, as the spinous processes are clearly palpable of the patient's skin. In this video, you can observe our results in spine surgery. An ischemic field over the surgical area is obtained. Good analgesic result with reduction of 75% morphine consumption during and after surgery. It is an easy procedure to perform when the patient is under general anesthesia and in a prone position. It is required 15 to 30 minutes for the effect of epinephrine to be maximum. Must be carried out with strong aseptic measures since the injection will be performed on the surgical field. After more than 100 procedures performed, we have not found any secondary effects such as hemodynamic, infection, or necrosis. Must be agreed on with surgical team, since the surgical field will become significantly edematic. Thank you for your attention, and special thanks to my friend Alexa, who did a great job. Thank you, Alexa.
Was a great pleasure.